Okay, for everybody else as well, this is a very common question that we're seeing. Do we know the efficacy of the vaccines in myeloma patients? So what percentage of patients in your clinics are you seeing that are developing antibodies to it? Are there certain drugs that you're noticing patients are on that make it more likely for them to develop antibodies? And are there certain drugs that they're on to make it less likely? Like I've heard something about daratumumab, but I don't really know if that's accurate or true. And I think we should all, because you all treat a lot of patients in a lot of populated areas, but different parts of the country, which is super interesting to me. So I'd be interested in hearing that answer from everybody.
Dr. Gertz, you go first.
Thank you, Faith. In my clinic, approximately 80% of patients have protective antibodies against the spike protein. And so for today, I think those patients can behave relatively normally. And the Greek myeloma study group presented at the International Myeloma Society that Darzalex clearly is reducing the ability to respond to the vaccine. So there's no question that has an impact. Probably speaking to the choir, but of course, that's today's answer. But now there are now being reports of fully vaccinated individuals becoming infected and sick with Delta variant. And that, of course, is quite disturbing, because the way I interpret that in my worldview is that people who refuse vaccination are putting the entire myeloma community at risk of getting seriously ill, because virus is still being transmitted. In Minnesota, 110 cases a day of COVID, all of whom are unvaccinated. Right now in Minnesota, there are no vaccinated patients who are being hospitalized with COVID. They're all unvaccinated, but there are reservoirs for mutation and genetic drift to develop more aggressive variants that could harm the population. So today, if you've got antibodies, I'm telling patients you're safe. I have no idea what the right answer is going to be a month from now.
Yeah, no, so I completely agree with Mori. I think, there's a couple of groups that have already published their data about vaccine in myeloma patients. The Greek team are probably, the Greek team and the Marsden team of two of the groups, and they're showing about 70 to 80% of patients. The patients that seem to be struggling to mount an antibody response are those that have had daratumumab or anti-BCMA. And I guess to some extent that's not a surprise, because those specific drugs target both your myeloma plasma cell and your normal plasma cells, and you need those normal plasma cells to mount your response. So if it is possible to get your antibody levels measured, this isn't necessarily always possible, but if it is, I think that would be worthwhile doing. It's not all patients who have had DARA, and the Greek group weren't able to figure out, sorry, my husband has just walked in the door and we're live. So I apologize. Because most people get interrupted by their dog or their small child. Me, it's my husband. I apologize. I don't have a train of thought now. Yeah, so if you can get your antibodies, then please do get them checked. I actually also agree with Mori as well. As somebody who doesn't have myeloma, I still, when I'm in a crowded area, wear my mask, because there's just this little kind of thing in the back of my head that's like Delta variant. Are we 100% concerned? We, sure, in 3 months' time, are we all going to be going to get a booster, et cetera, et cetera. So I'm probably super cautious, but I still wear a mask in a crowded area.
And what's a good level? I mean, like if you have it, and let's say because I got COVID back in January and I never got an antibody test to see if I responded, but I did get vaccinated. Now I have had a really strong response. So I'm just kind of curious, like if you have a sufficient antibody level after having COVID, do you get the vaccine anyway, just as a double measure? And okay.
Right.
Okay,
and on average, your COVID, your response to the capsid or the nucleocapsid, the median duration that they've published is approximately 7 months. So you're going to lose that. You're more likely to keep the response to the, we have best data for the mRNA vaccines that it lasts longer than a year. So I think that, getting the vaccine, it makes sense. And, the idea of a booster was just published on Wednesday this week in the New England Journal looking at solid organ transplant patients, demonstrating that those patients that didn't have a great response after 2 mRNA vaccines were able to boost their response further with the 3rd dose. So again, it's likely over the summer the concept of booster shots in appropriate patients is going to be more and more attractive.
In our laboratory, the normal level for an unvaccinated individual is less than 0.8 units per ml. And for spike protein, most vaccinated patients are over 250. So that's what we're looking for normally.
Okay. I'll have to go back and look at my numbers because I did get numbers. So interesting. Okay. I wanted to ask a question about, we talked about high risk myeloma in both of these sections. And a lot of patients had questions about this 1Q gain specifically. So is 1Q gain the same thing as 1Q amp? When is it high risk? What does it do? I'm kind of curious. What does 1Q gain do genetically? And can you all kind of address the 1Q gain, because we had just a lot of patient questions about that particular feature.
Shall I go first?
Who wants to start?
Okay. All right. So there's all sorts of debate and discussion about 1Q. Okay. So to start off with, there is a 1Q gain and a 1Q amp. So you should have 2 copies of 1Q. A normal person has 2 copies of 1Q. Sometimes in a myeloma cell, you can get a 3rd copy. So that would be a gain. Sometimes you can get a 4th, 5th, 6th, 7th, or 8th copy. That would be an amp. Okay, amplification. So if we're just looking at 1Q gain, it's actually quite common in myeloma patients. It can be up to 40% of myeloma patients that get a 1Q gain. Hence why it's difficult to say it's a high risk abnormality, because there's so many patients that have it. You suddenly end up with all your patients having it and things. So to some extent, it's not just having the 1Q gain, which is the problem. It's if you have that with other things. Okay, so for instance, a 414 or a 1416, then it starts to add to the number of risk factors. Okay, now why is that area particularly important? We don't know. Okay, there are lots of important genes on that bit of the chromosome, ones that control the growth of the myeloma cell, ones that stop the myeloma cell dying, and people are trying to figure out exactly what the issue is there. There's also this ability of that bit of the chromosome to really effectively move and kind of amplify itself up and put itself in front of other genes, which is why it can, when you've got this amplification, be really problematic, because it can actually stick itself in front of other genes that we hear about quite often, such as MYC and other genes like that, which can be really important and make those go really crazy. So I think that there's so much controversy about it because we're learning about it all of the time. But the short answer is, on its own, it's not necessarily a bad thing.
Mm-hmm. Okay, great information. Anybody else have any comments in the context of high-risk myeloma? Is it more common to come with another mutation?
Yes. So, okay. Often once you get one, you can often get the others on top. So, and they tend to, it's not all random, I guess. They do tend to kind of cluster a little bit between different things. So you can, so for instance, just as we know that a 414 will often kind of be buddies with a chromosome 13 deletion, the 1q can often buddy up with things as well.
Okay, great. Okay, Vicky's suggesting that we take a soundbite of you, Dr. Gertz, and include it on all social media. So we will write an article with an update about the comments that you've all made about COVID, because patients are constantly looking for updates. So Dr. Hoffmeister and what everyone has said about COVID, we'll bundle those together and write an article about it. And then Vicky, you can share. So we appreciate that. Okay, let's jump into more questions. So Dr. Hoffmeister, Jack wanted you to address my myeloma is resistant to RVD and DRPD, so now what? This is kind of a more broad question. Because there are so many treatment options available to patients now, both in the context of clinical trials and, treatments that are available, how do you respond to that when patients ask you those types of questions?
Sure. Certainly for patients who, again, a little less fit or by choice, they decide to are exposed to RVD initially and relapse, then get DARA and Pomalyst and dexamethasone and relapse. And often those folks on DARA, POM, and Dex are on usually DARA and POM at the time that their disease becomes resistant. Then the question is, well, really, what's next? So there's a bunch of options now trying to look for risks and benefits. Certainly in those patients who are 1114 translocation patients, this is a reasonable time to discuss venetoclax and dexamethasone as third line. Not always easy to get it paid for. Certainly would be a great time to enroll in one of those 1114 clinical trials that are ongoing. But
For 3.
Yeah, and so that would so yes, that would be most appealing there. For those who are not 1114, then the question is there a local clinical trial that looks appealing? That would be great. Sometimes those are new and innovative, but then you're left with things like Blenrep. You're trying to do 3-drug therapy, switching out the Darzalex for Kyprolis, and you're not usually treated with enough lines to get access to Abecma, and even getting access to a pheresis slot for Abecma is quite challenging nationally at this spot, or at least at my center, and at a bunch of other centers I've talked with, but maybe not every center. Blenrep has a side effect profile which is unique in that its eye problems and low platelet count are different than things like selinexor, which don't seem to cause any eye problems, and are predominantly can cause nausea and malaise. So that gives it a unique perspective, and some people are thinking selinexor at that third line setting, and others not. So trying to individualize at that point would be appealing, but there seems to be a number of options, and no one is a winner. Having just had this conversation with a patient who's very uneasy about clinical trials, I tried to emphasize that the reported response rates for BCMA-directed bispecific antibodies is pretty darn good at the recommended phase 2 doses, and the reported response rates for anything commercial is half of that. So if a bispecific happens to be available and to that patient who's getting third-line therapy, I would consider it.
Mm-hmm. Okay, anybody else have any other comments?
I would make one thing, and if Faith doesn't agree with me on this, I'm going to be shocked. and that a lot of the younger oncologists who grew up in the area of novel agents think only about novel agents. These are times when patients get referred and they've been received a lot of therapy, but they have not seen cyclophosphamide, which I knew, Faith, because we're kind of the same generation almost. And cyclophosphamide in higher doses, I mean, a good pulse of it can be very effective and be done as an outpatient. And it's an oldie but a goodie. There's no question people come and they've never seen this drug, so the myeloma cells have never been exposed to it. And a parallel that's been reported is bendamustine, which is kind of like cyclophosphamide, is usually combined with a third agent. But when patients who, by all rights, as Craig said, should be on a clinical trial, this is the time to seize the day and get on the ground floor of the next new big thing. If that's not possible, then the consideration after they failed 3 IMiDs and 2 proteasome inhibitors and an antibody is an alkylating agent.
I definitely agree. And it's quite interesting because we always think of our shiny new toys and we forget some of our old ones. And a clinical trial not so long ago actually decided it would compare its new shiny toy to cyclophosphamide. And it was really interesting because there was no difference at the end. So cyclophosphamide is a good drug. Yes, if you can get the new drug, no issues whatsoever, go in the clinical trial. But I think it's worthwhile remembering about cyclophosphamide and bendamustine. Yeah.
Mm-hmm. Now, Dr. Gertz, prior you mentioned, and I'd like everybody to cover this topic, but you mentioned that the bispecifics sort of might overtake some of the CAR T that are being developed. Can you, as a group, I asked this in the same question in the prior group, but everyone's perspective is so different that I'd like to hear it from this group as well, because it's confusing.
You're asking.
Well, my question is like, what are the pros and cons of bispecifics versus CAR T?
So, I was just speculating as a futurist. We haven't seen the optimization of CAR T. I mean, there's a lot going on with CAR T to ensure that the reconstructed killer white cell persists in the body and doesn't go away after a couple months. There may be mechanisms to prevent the myeloma cell from burying the expression of the BCMA so that it can escape detection by the killer white cells. And so comparing with today's CAR T may not make any sense because CAR T is going to continue to go on. And as you know from the chat, there's now not just CAR T, but CAR NK is being looked at. Allogeneic CAR T is being looked at. And so there's a lot of developments. And so I'm not closing it. But of course, CAR T in its current form, there are still a lot of people who have the myeloma come back in a relatively short period of time. And that the people who are disease-free for long periods of time is not as many as we would like. And CAR T often requires that bridging chemotherapy during the 4 to 6 weeks of construction and the chemotherapy to prevent rejection of the CAR T, the so-called lymphodepleting chemotherapy. And of course, you have to go live somewhere else. Most people don't live driving distance to a center where they have to be monitored very, very closely for the neurological as well as some of the chemical side effects that occur a day or two after CAR T infusion, where the bispecifics are off the shelf, can be given locally, and we don't know where they're going to end up. But I can see, at least, just to keep my answer short, this being very competitive with CAR T as things move along.
Okay, great. Thank you for sharing that perspective. Dr. Hoffmeister and Dr. Davies, your opinions also?
Okay, I'll go. I think so. I mean, let's not forget the problem with most first generation CAR Ts is their exhaustion. Is that they peter out very quickly. They get most of their bang for your buck in their first months, and we can't find them after so long. That's the story with ide-cel commercially as Abecma. It seems it may be less of an issue with cilta-cel. Maybe cilta-cel just happens to be a whole lot more effective in that first couple months than ide-cel. I really don't know. But one of the things that's interesting is that, you know, patients who have relapsed on Abecma may still have plenty of BCMA, whereas patients that relapse on a BCMA-targeted bispecific may develop target-negative myeloma, so they don't have any BCMA on their cell surface, and so less likely to get much response from a subsequent CAR T, whereas the reverse is not true. And of all the bispecifics available, it sometimes feels like somebody put some catnip in the bispecific bin, because there are so many bispecifics, and it feels, and they're not at all similar. Some of them have significant neurotoxicity. Some of them have significant infection risks. They're cardiac signals. So it's this and that. It's not as easy to differentiate the bispecifics in one bin. But in the future outlook, it certainly is nice, the idea of having a bispecific that you could potentially start, you know, even same day, whereas a CAR T, even in the best of worlds, it's weeks away to manufacture. So a bispecific seems good for a today buyer, using a car buying analogy.
Great.
So I think our opinions are going to change over the coming year.
Sounds like it.
Yeah, and so I don't think we truly know enough about either of them. So I guess if you're thinking between a CAR T and a bispecific now, go for whichever you can get hold of, okay? Because they're not widely available. And so the truth is, at the moment, it's not really a choice. Just go for whatever you can get, okay? In a year's time, I'm not sure that we will have addressed all of these questions, but I think that we might be a little bit closer to addressing some of them. And it may be that it's just comes down to patient and physician preference, as in what's available and closest to you, okay? Or there may end up as some medical kind of nuances as to this is better than this. But I think that's what the next year is really going to teach us.
Okay, well, it'll be exciting. Judy's asking a question for newly diagnosed patients that's personal, but I think this is a question that can be more broad. When you're newly diagnosed, do you start treatment if you have to wait to see a myeloma specialist for like 3 or 4 weeks? Do you go ahead and start treatment with RVD or something like that? Or do you wait and go to a myeloma specialist? Important question, I think.
I think it depends on the urgency of which treatment is required. I mean, if this is being driven by a progressive decline in kidney function, that's time sensitive and urgent. If it's being driven because you're anemic, then there's more time flexibility. And for me, one of the most frustrating is that a patient starts treatment and sees me a week later. And that frustrates me because we have some brilliant clinical trials, cutting edge stuff for newly diagnosed patients, and they got 1 dose or 2 doses of something, and they are no longer eligible to reap the benefits of these trials, which have been developed by global thought leaders that understand how to push the envelope and improve outcomes for myeloma. And patients say, can I be on a clinical trial? I say, last week, yeah, this week, no, you've been treated, so you can't be newly untreated patient. And so, again, it depends. I mean, obviously, if you have a pressure on your spinal cord, you can't wait. If you have some low back pain that you're managing and it's going to be a week or 2 more, probably it's worth the wait just to find out, can I get something treated from you that I can't get from my current doctor?
I love that answer. Okay, anybody else? Because isn't testing kind of a key issue here too?
I was going to say, so I think it's important to have that conversation with your local doctor to find, as Mori said, to find out whether you are stable enough or not. I think the other question, because the last thing any of us want is for a patient to develop a back issue or a kidney problem having had that weight. So that's an important thing. But I think also in amongst the testing as well, sometimes as well as the availability of clinical studies at a specialist centre, sometimes the doctors at a specialist centre might have some slightly different diagnostic tests that may help with the patient's kind of myeloma treatment, be that some of these genetic tests that we were talking about earlier that may not be available at some of the more smaller, more general oncologies. So I think that might be important too.
Just getting the right tests run.
Well, I would also say occasionally, this is occasionally, but I'm sure my colleagues will agree. Occasionally I see a patient who is about to embark treatment comes and I look at them and do the evaluation. I go, yeah, I don't think I treat you yet. I just keep watching. And so that's the difference between getting treated and being observed for not forever, but maybe delaying treatment for a year or 2 years. And so just because someone says you need treatment, and I think they have to weigh in, my colleagues, doesn't always mean you need treatment.
Yeah, and also the other side of that same situation that has occurred to me numerous times of patients who are just about to start, DARA KRD, and I'm like, I wouldn't treat your low-risk smoldering myeloma with DARA KRD. That seems a little aggressive. And on the other hand, I've also had the heartbreaking patients who've had 2 compression fractures. And they're like, well, it just, the myeloma was 9% in the bone marrow. I think we should wait. And also similarly drives me nuts. So I think time is nephrons, basically time is kidney function, time is bone health. So if you have somebody who has kidney damage or bone damage related to their cancerous plasma cells, starting treatment is certainly extraordinarily appealing because you only get one back and you don't get it back.
Yeah, that first line of therapy, and Judy's kind of asking that same question, like, do you add DARA to RVD in a newly diagnosed patient? I think you need a myeloma specialist to kind of lay out all the different options based on your personal situation. So it's not really something that you can answer in this context, but you really need a meeting with that doctor to say, what are my options? What centers do have these large numbers of clinical trials that are running? It's worth a consult every time, in my opinion, for a newly diagnosed patient and a relapsed patient, because there are a lot of options, and every choice we make is, like, I always say this, but like a chess game, and it's with your life. So don't take it, it's not insignificant. Take it seriously and come to you who are treating this disease in hundreds, if not thousands of patients. It's just,
Don't forget the video option now, where you don't have to travel.
Telemedicine, right? Yeah.
The thing to say, Jenny, as well, is in my experience, most community oncologists are really happy if the patient sees a myeloma specialist as well. They're very rarely, patients are often concerned they might upset their local oncologist or anything like that. That has not been my experience at all. Most oncologists are very happy to have a more specialist person involved in the care as well.
Mm-hmm. Yeah. Okay, there's some questions about, Gail's asking a question, when do you expect CAR-T will be available in newly diagnosed patients? Dr. Weissel talked about a study in 2022. It will open, not just, I know there's a high risk study open, but study will open for more broadly. In the United States, where do you see that heading? Because some patients don't know that you start in the highly relapsed setting, you kind of move your way backward to the newly diagnosed setting. But when can we expect that?
Well, there is the KarMMa-4 trial. I'm sure there's a cilta-cel-based clinical trial looking at CARTITUDE something or other that is looking at the incorporation of BCMA-directed CAR T in newly diagnosed patients. So certainly those clinical trials are up and going and looking to see responses.
Okay, great. Patrick is asking, is it true that for Dr. Gertz, is it true that 25% of myeloma patients also get amyloidosis?
Oh, that's not true. I mean, if you have full-blown myeloma, I mean, really bones and kidney and anemia, amyloid is very, very low. It's certainly under 5%. The problem is that there are people who have been diagnosed as myeloma because of 15% plasma cells, no bone lesions, and their problem is they're fatigued and they're short of breath. And no one thought about looking for amyloidosis. And so the ratio, the actual prevalence of myeloma to amyloid is about 5-to-1. So there's one de novo amyloid for every 5 myelomas, roughly, based on national statistics. But I can tell you that in a newly diagnosed myeloma patient with the usual anemia or bone or kidney, I do not screen for amyloid. There has to be something else to screen. I would never routinely do things because sometimes you find positive results that don't mean anything. And that if you have full-blown myeloma, the risk of developing amyloid later on in the course of the disease, it's clearly less than 1 in 100.
Mm-hmm. There was okay, thank you. Dr. Kaiser talked about some of these newer therapies. Like, I think we've kind of, it's been interesting in myeloma to see the personalized medicine wave kind of come through with targeted therapies, and then now see the immunotherapy wave come through that are more broad and in general. He had been talking about BRAF and targeted treatments like that. Can I just ask a philosophical question of you as myeloma experts? Like, where do you see those things converge, and where do you see those things? Because it seems like it'd be really hard to just target a BRAF mutation in patients and have it be super successful in myeloma versus this immunotherapy idea where you're teaching the immune system. Do you have thoughts about that? I'm kind of curious. It's more of a philosophical question.
I'll go first. I think we probably all have slightly different thoughts. So I think there's a place for both, okay? So one of the problems just generally about myeloma is it's sadly incredibly clever. And whatever you throw at it, it can potentially learn how to overcome it, okay? And so the most experience we have with this is with many of the treatments we've already had, but also things like the BRAF mutation and the BRAF inhibitors, where you can give that drug, it can get the myeloma under control, but then the myeloma rewires itself and starts to grow again. At the moment, we don't have so much experience with the immune therapies, but given how intelligent, dare I say it, myeloma is, it's not going to surprise me if it learns to rewire itself and to overcome the immune therapies as well. And so as a philosophical question, my argument would be, in the long run, we are going to try and put these things together to try and kill the myeloma cell off itself. And if we can get that level to a low enough level, that it then can't learn to rewire itself. And so essentially use the whole army, be it immune, cytotoxic, targeted, whatever. The issue is at the moment is that we don't know what the combination is of those different things to put together. That would be my philosophical answer.
Okay. Dr. Gertz, what's your opinion?
I'll defer to Dr. Ho. I don't really think I have much to add to Dr. Davies. It's an evil disease. And we need more opportunity treatments, and I can't predict what the next great thing will be. I'll turn it to Craig.
Yeah.
Well, I was just going to expand on Dr. Davies' clear way to think of it is that, there's a couple pathways that define parts of plasma cells, right? The 11-14 translocation seems to be
perfect.
Those plasma cells are sensitive to venetoclax after 1 line of therapy, and they're almost equally sensitive after 6 lines of therapy. So that pathway is pretty active, and those plasma cells are dependent on that pathway their whole lives. And, you know, the IRF4 cereblon pathway is kind of foundational. And, you know, there are companies that have kept alive just on that one pathway and making things just a little bit better and a little bit more tolerable on that one pathway. So I think at least those two things intracellularly are remain quite prevalent in all plasma cells. And, you know, you could see them being included in the future with almost any immunotherapy due to their importance.
Okay, well, great way to end it. We have a lot to think about in myeloma. We could talk for hours about what's happening in myeloma and the research that you're doing, because it's so stunning about what's happening. But I thank you, Dr. Hoffmeister, Dr. Gertz, Dr. Davies. Thank you so much for your time today. Thank you, everybody, for participating. We will be sharing this and producing it following, so it will be available on our Facebook link as well as in a post later. Thank you so much for giving us an update on ASCO and EHA. Great time point and great presentations. And with that, thank you so much.
Thank you. Take care.